to offer these opportunities for alumni. So our continuing education webinar sessions provide health and wellness resources, unique opportunities to learn about critical nursing topics, and tools to improve quality of life for UC alumni and the Bearcat community, which includes nurses all throughout the Cincinnati area. Be on the lookout for more webinars soon if you need continuing education credit. So for those of you online, just a few housekeeping notes. Please make sure you are on mute to prevent feedback and background noise. And if you have any questions during the session, you can type them in the chat box and we will look for those towards the end of the session. We are recording the session today for those of you that are online. So if you need to watch it back or catch anything, this will be on the College of Nursing website sometime next week. So again, thank you all for being here in person and online. And at this time, I'm going to go ahead and turn it over to Dean Rebar to introduce our speaker for today.
Thanks, Megan. Thank you, Megan, and welcome everybody. Thanks for coming out on a Friday morning. I know it's not always the best to have to be in person on a Friday morning, but I appreciate everybody that's in the room and everybody that's online. Thank you. I want to also take opportunity to thank all of you. I know many of you in this room were involved in our recent accreditation visit, which was incredibly successful, thanks to many of our people, particularly Dr. Rich Pryor sitting right here, who's our Senior Associate Dean, so thank him very much. He did a wonderful, marvelous job. And so our continued accreditation will allow us to really step into some of the innovation that we're going to be talking about this morning. So on that, I would like to introduce our keynote speaker, Dr. Ryan Shaw, who is over here. He'll be coming up in a minute. Dr. Shaw serves as the Chief Nursing Innovation Officer for Duke University Health Systems. And his main focus is being able to leverage technology and evidence-based practices, and he identifies opportunities to empower nurses to thrive as change makers, address healthcare delivery challenges, and improve patient outcomes and enhance efficiencies, which is what we all want to do in our jobs, right? Every single day. So in his faculty role at Duke University School of Nursing, he leads research teams driving digital transformation in healthcare. His work has been supported by organizations such as the U.S. National Institutes of Health and the National Science Foundation, among others. He is passionate about mentoring students to become the next generation of health scientists and clinicians, and we welcome him to the stage.
Thank you so much. Yeah, thank you. Can you guys hear me okay? I think so, yeah, it's pretty echoey. Yeah, well, thank you so much for being here today and for the invitation from Dean Rebar and from Dr. Cheeks, and to all of you for taking the time today to be here. So I'm really excited to speak with you about nursing innovation. Just going to pop down here, and really how things are really rapidly changing within our new digital age within healthcare. So just to provide some context, so I've been in this health system role for just over a year now. I was coming over from the academic side, and I have learned so much. It's almost as if I've started a new chapter of my career, not totally knowing what really, how, challenging I would say health systems really have it right now. And just to make sure that everybody who is here and online too, I just wanted to provide some additional context. Not sure what that was, but so just a bit about health system challenges. And I know I'm preaching to the choir right now. So I think this is the biggest one right now, is that demographics are changing. Fewer children are being born since 2008, and 18 years later, there are now fewer students coming into the overall workforce. Meanwhile, the population is getting older, and so there's going to be an increased demand for patient care and increased demand for complex patient care. On top of that, there's this big drive to really shift care to be at home, away from the more traditional acute care settings. Right? So this is like the macro level trend. And we will really start feeling this by 2030, after the next 4 years, where those children are now starting to more enter into the workforce, and hopefully becoming nurses. In addition to that, I'm sure all of you have been feeling this, right? We know that there's burnout, it's quite high. We're still going through a workforce shortage, which I've been a nurse for about 24 years now, and it's always been a workforce shortage. But it's not getting easier too. Nurses feel cognitive overload, and this increases this really impacts patient outcomes and safety risks too, right? And so I'm sure many of you are also faced with many financial challenges, right? Where labor expenses, especially from the pandemic, increased travel nursing costs, which I didn't really know from the academic side how much that had impacted health systems. There's this reimbursement gap, and then there's these AI payer wars. Here we are thinking that AI was here to help us, but then at the same time, it's causing challenges. And then we have rising non-labor costs too, and policy volatility, right? So all of these different challenges going on. And so maybe you've gotten some email, something like this, not exactly, where is that going on? There you go. You get this urgent email from your VP. We need to cut $2.4 million from nursing operations next fiscal year. Travel nurse contracts are unsustainable. Turnover is at 22%, which in some units, that might be a good goal to get to. And the board wants a plan by Friday. Also, I hear that there are complaints from the medical staff about discharge delays. Can we meet tomorrow, right? And so the question is, how would you respond to this email? Mike? Yeah, please, no, tell me. Did this resonate? Oh, goodness. So my goal is by the end of this talk, your response might be a little different in your approach to how you might respond to this. So just again, laying the groundwork of kind of a lot of these, pressures. And so the question is, what are we to do, right? All of these challenges are going on. Do we just sit back? Absolutely not. Like, we are nurses. It is our imperative. It is our responsibility that if all of these challenges are going on and the current system is like this, we have to redesign care. We have to redesign models of care to meet what the future is going to be like, which hasn't yet happened. So we have to continue to build and foster a innovation culture in nursing. As the largest healthcare workforce, we have immense influence, or at least we should have immense influence, to really be able to innovate and to design new patient care models. And we know that we can do this. Just a few quick examples. If we build the structure in the processes, we can empower a frontline staff. Like, this is a former student of mine, Mary Beth Tetlow, a pediatric ICU nurse. She invented the line snuggler, which is this a device down here which wraps around a patient's IV lines because she saw a frontline need. We can also have nurses work with engineers. This is Sam Fox, who invented a sheet that overlays on top of a bed so that a single caregiver can turn and boost patients. And during the pandemic, as nurses, we came together to be innovators. It was important. It was an imperative. People invented things like these 3D printed face shields, and maybe some of you maybe use these, or you maybe even printed them here too. So the idea in nursing that we can be innovators is not new, and there are great examples out there of where these structures are in place. Sorry, it's kind of echoey. So some of the objectives today are to understand innovation nursing, describe some of the major drivers, types, how we lead and support innovation, and a bit about the digital health landscape. And I'm going to do this by largely going through a current case study that I'm involved in, and then do a little bit of some audience participation. So, what is nursing innovation? Right? So it's the application of novel ideas, methods, technologies, or processes to improve patient outcomes, clinical workflows, or healthcare or delivery. And it's not just improvements. So at our system, we struggle with what's a improvement versus something that is truly novel, because we only have so many resources. So we do struggle with being able to align things to make sure that we're moving forward over here versus just fixing things. But these can be nurse-driven, these can be processes, technologies, and they really need to be outcome-focused too. But don't just take my word for it. The ANA is making this part of our standards, and there are new definitions that are about to come out that says that innovation in nursing is our job. It's part of the work that we do, and it's critically important because, again, we are healthcare. And so when it comes to nursing and innovation, we can think of this through different frameworks. There's quite a few out there, but it comes down to processes, thinking about workflow, or a documentation. It's a big one right now. Optimization, standardizing protocols. At our system, we've been growing, and as we add more hospitals, they're quite different. Even the titles of people, protocols here aren't the same over here. And so we're going through a shift to try and standardize all of this across what is now 4 hospitals. And we're not a big a system, but also not small. And so it also falls under in care models, talking about virtual nursing, which is going to be the case study, technology enabled, which is the elephant in the room right now, especially around AI, and really thinking about workforce and our culture, and really even creating new roles for nurses in the near future. Sorry, this is kind of hard. Okay, is that better? All right. Sorry about that. Okay, so leading nursing innovation. So nurses need to be architects in the new world of digital health, and this includes being strategic visionaries, being able to identify clinical problems that technology can solve and to champion and to be co-designers. We need to partner with engineers, IT. We need to be change leaders, and we need to drive adoption through engagement, and we need to be evidence builders too. So the case study, just out of curiosity, who all here at your system has yet implemented virtual nursing? Any of you guys? Some of you? Okay. How far are you approximately? What would you say? Where are you at now?
We're at the Christ Hospital. We are 2 years in October.
Okay.
And we are trying to do like a team care model, which is challenging with staffing issues and things like that. But that's the way that
Okay.
we have cameras and hardwired in every room.
Okay. Yeah.
The communication is through the television set.
Awesome. So you may be a bit further along than we are in some ways. So I'm curious to speak with you afterwards.
We also have the ICU.
Okay. Awesome.
But they operate more like as needed, not
Yeah.
assigned to
Okay. Interesting. Good. And yeah, please.
None of our current organization. In the organization I came from, we were experimenting with admission and discharge support just on a homegrown little fancy telehealth apparatus
Yeah.
attached to a mobile card.
Yeah. And did that spin out of the pandemic? Kind of came out of a need out of that?
The availability of the technologies went out of the pandemic,
Yeah.
but we were just trying to figure out how to bring more support to bedside nurses.
Yeah. So that is a story that, has pretty much happened all over the country, right? There was this need for delivering distance-based care, not using too much PPE, and that really spurred inpatient telehealth. So there's some irony there that from all that. And so for us, virtual nursing is one of our key strategies for what the future might look like, including at home care too. And so just like yourself, we've been focusing on admissions and discharges and a patient safety focus and on workforce optimization. And, oops. Yeah. Sorry, this thing is hard to use. There we go. And so for those of you who may not be that familiar with what virtual nursing might look like, this is a portable version, if you will, a nurse on the floor firing a iPad into the patient's room. They set this up through the electronic health record, and then the patient gets into a queue where a virtual nurse in a remote care center is then able to deliver, in this case, it's discharge instructions here. And so, staff are, their opinions about this vary, right? Some of them feel like this is adding more burden to them. Some of them really like it. And I'll show you some data about this. And so kind of that, just briefly, what this workflow looks like is there's a task assignment. In this case, it might be discharge planning. It could be the admissions also. You connect to the video. The virtual nurse completes that workflow, and then they then document it in the EHR. And so we've recently been measuring this to see what patients and what staff think about this. We called about 110 patients. And on a scale of 0 to 5, what would you say the satisfaction was among patients who had been discharged by a virtual nurse? Any thoughts? High or a low? Yeah, kind of. Yeah. All right. Well, to our a surprise, it was actually 4.6. And what patients said is that, wow, I was really skeptical at first, but that virtual nurse, they really took the time to talk to me. They knew everything about me. They knew my medications, my plans afterwards. They called the social worker, the pharmacy. And so that virtual nurse isn't getting pulled away into all of these other rooms having to do all these tasks. They have dedicated time to do all that. They're able to answer most of the questions. Only about 4.5% reported technical issues, which I think that is pretty low, because I don't believe that. But this model, we've had like rapid growth. And for those of you who have implemented this, I'm also curious to hear if you've had similar outcomes too, because we have to learn from each other on how this goes. And what I thought was really interesting is that for every 6 nurses supported by a virtual nursing for a year, we've been able to prevent turnover. Yeah, please.
Did you look at length of stay?
So we are looking at that next, right? So the challenge here, and this is where this case study is going, is that this solution is not complete. And that's why I'm curious to hear about you guys putting like permanent fixtured cameras in there. But that's the big pressure, right? Decreasing length of stay, preventing readmissions, and preventing harms, right?
We looked at length of stay because we were trying to justify an economic reason why we'd be able to expand. I did not expect but I thought with the discharge support, we would see a reduction in length of stay. We actually saw it with admission support, a half-a-day length of stay reduction.
Wow.
In a kind of case-controlled analysis done by finance, not by me. But it was a small cohort, and I doubted the results. I wondered what you'd seen.
Yeah. So this a solution here, while patients and staff are favorable of it, it's still unlimited by it being portable, and someone has to bring that iPad into that room, right? And so there's not that fixed structure, at least until now, that we have to really drive that length of stay, right? Getting patients out the door and everything coordinated in time. I'm curious if you guys kind of have experienced these similar challenges. So while this has been good, it's really just okay. And so some of the lessons learned is that there's hardware instability here. Sometimes the Wi-Fi drops, there's all these echoes, there's this workflow dependency, which has kind of been our biggest challenge, and there's limited autonomy from that virtual nurse to really pop into that room whenever they want to be able to deliver care. So while these portable devices have really fostered early adoption, it's not really a enterprise-wide solution to really drive those outcomes that you're talking about of like length of stay, at least in our experience. So we're now moving from this portable solution to this fixed in-room camera ones, where at this point we've installed 94 cameras across 3 pilot units, and these we call our innovation units, and they're really dedicated spaces to validate technologies and also care models that are standard of care, and so they are part of the clinical workflow, and we use these to make business decisions. If these technologies prove a return on their value, then the health system can be better informed if we should then scale those. And so we just started this this month, and sorry. Okay, and so. I hope, right. So, going through a typical PDSA cycle here, right? We design the evaluation, the use case, design a robust QI method evaluation. We then deploy it, collect that data, study it, analyze those findings, look at the impact, and then we use that to make those to make the upcoming decisions if we're going to go system-wide. And so these are our 3 units at Duke University Hospital. The staff are really on board with them. They have to be on board because we're changing their workflow. And again, the goal is to really focus on testing here and then being able to scale. Okay, and so this is a illustration of what it kind of looks like. So this is what it looks like in the room, right? It's this 2-way camera here, and we've also combined it with this electronic information board, which I'm curious if you guys have also implemented that. And so we use these units to test out these different innovations. So it's not just virtual nursing, it's adding more technologies on too. In fact, this electronic information board is a controversy. And the biggest thing about it is that estimated discharge date. So providers, they do not want that date. The hospital does, because we get a decreased length of stay. Like, you need to know when you're going to be going home, right? But that date has to be updated on time and has to be accurate. So that's our current, everyday a discussion is, should that discharge date be up there? And do any of you also deal with this too? Yeah, okay.
Christ Hospital as well. Our units, we have the electronic whiteboards, and we do have the EEG on there, as well as my chart bedside.
Yeah.
So help the patients with expectation setting.
Yeah. Do you think that has helped to drive outcomes, or unclear?
No, I think it's really hard because there's so many initiatives around discharge and length of stay, and so what is that one driver? I'm not sure that there's ever one tool.
Yeah.
It's a collaboration. disciplinary work.
Absolutely. Yeah, and that's a big challenge there too, is like really trying to figure out what's causing that effect, right? What is driving outcomes? And so that's one thing I tell our leaders is if we test too many things at the same time, you're not really gonna know which one is doing that to be able to scale. Yeah, please.
Health, we have whiteboards in our emergency departments. And actually, it was an early innovation for us pre-COVID, but it really helps just as a former user of it occasionally to know where you're at. Like, what am I waiting for? Who's my doctor? So like a mini care plan. Just
Yeah. Nice. Yeah. Very good. Yeah. And so this is where we need to come together and like share all of these best practices too, and clearly at conferences, settings like this too. And so we've called this the co-care model, and I just want to put up some of our team members because this isn't all being created by me by any means. And this is what it actually looks like at the end of the day, rather than those nice, pretty pictures too, because vendors love to sell you something that might be slightly over promised at times, but really this is led by our nurse managers there, and it's just so important that they are on board because they're the ones that are really there at the front lines with the staff. So, and the goal of this co-care model, right, is where patients now, right, they both have a bedside nurse, but they'll also have a virtual nurse too, and the nurses that work on the floor also work in the virtual care center 1 day a week. And that model is what everyone's trying to like figure out. What's the best one? Do you only work in a virtual care center? Do you do 1 week here, 1 week there, 2 days on the floor, 1 day in the virtual care center? So, I'm on these calls and like everyone has different models. And so if anyone has figured this out, please let me know. It's also combined with remote safety observations, right? So we don't have enough sitters, right? And so can we leverage a sitter who's looking at multiple screens at the same time to prevent like falls or to help with other tasks too? And so so you go through these discussions about, well, what does this new team model look like, right? What can the virtual nurse do versus the bedside nurse versus shared team tasks, right? So the virtual nurse can do admissions and discharges and things that don't require physical touch, while the bedside nurse then has more time to really spend on doing, direct patient care that does require that. But then we also have shared team tasks too, right? Doing care plan updates, second signs, being able to review the chart. And now we're thinking about, well, can that virtual nurse do chart audits and making sure that we're doing billing prior to discharge and making sure all of that is going on, because nursing is the continuity there, right? And thinking about, well, what can the virtual nurse do? What are some of those high impact responsibilities that they can do around safety and quality and being that discharge navigator too? And also, again, can do sterile procedure checks, 2-person skin assessments, 1 in person, 1 virtual. And again, this is the ongoing case study. I'm going to keep going too. And why is this important? Well, we've got to think about how to redesign care because we need to give time back to nurses. We need to decrease that cognitive load, promote safety and also quality, drive satisfaction. Our nurses that work on the floor and as a virtual nurse, they really like that because at least they can get off of their feet, and they're still caring for the same patients, and they know everyone there that is on the floor too. And this is where nursing schools are going to have to go to also in terms of teaching these care models to meet the changing industry, right? And we've done some initial time studies where it does support saving time too. And in the interest of time, I'm going to keep going. And from a remote safety observer, dang it, you get sold by these companies about these AI algorithms. And when we were first getting into the space of these fixed in-room cameras, we were being told that the that these algorithms would prevent patient falls. And I was like, wow, that sounds great. But I was like, how does that algorithm in that camera stop that patient from falling? Like, isn't that gravity, right? And yeah, I know, I'm kidding, but it's also true too, right? And you just got to keep digging and figuring out, like, what are you really trying to sell to us? Well, what the algorithm does, right, it detects if someone is in a bed, and if they're getting out of a certain window, it will have the screen turn red so that remote safety observer is looking at that. Because they're looking at like up to 12 different screens. And so it really helps improve that cognitive burden and make sure they are paying attention to certain screens. And so the algorithms, just be careful about what you're being sold and make sure that you really understand what they are doing. We've also been told that these algorithms that are inside these cameras, which are vision-based AI, will help to decrease pressure ulcers. Kind of the same thing too. Well, it's a camera. How is that really going to do that? Well, it's more of like a timer and count where if a nurse is documenting that a patient has been turned or not, this timer starts to go down. The algorithm's not actually turning people. So, and if you do find one that does, let me know, please. So, all right. So my role in this is to actually drive how we might evaluate this. Really pushing the boundaries of a typical project and thinking about how we can really make a business decisions based upon real outcomes. And so what I've pushed us to do is, as we evaluate this inpatient telehealth care model, co-care, on these 3 units, to compare that against 3 control units that are of a similar makeup. And these are all 3 med-surg floors. And to do that for all of these new technologies and also care models that we are evaluating. And so our system at month 6 is going to make a decision if we're going to then scale this further. And then I'm going to come along after them and continue to monitor that for another 6 months. I got this push to be registered under clinicaltrials.gov. Even though they told me that it wasn't needed, but we should share this information. So, and now the questions are, well, if we have all of this inpatient care like this with the telehealth nurse in a virtual care center, well, can't we just give the patient remote patient monitoring tools in the hospital? And then when they're discharged home, we'll just continue to monitor them, especially now that about a month ago, Congress finally passed the new, telehealth reimbursement codes through 2027, where we can bill for receiving patient data according to different CPT codes, and a nurse could do that. So what if the nurse was discharging the patient goes home, and that patient sees that same nurse when they get home too? So starting to like smooth out this care continuity model, right? And so as policy changes, we need to be jumping on that to really be thinking forward about where we are going next, right? And it doesn't have to stop with home care. It could be hospice care. It could be wherever patients get discharged there. We just have to make sure that it's equitable, right? So that wherever patients are, they still have internet access, they can use wearables, or we can give them devices. But the payment models, they're there now, and this is new. And so, and we have data for this too. Part of my job is to bring in some of the research we've been doing over at the nursing school, and this is just a quick example of a 5-year trial. We just finished up where we gave 220 patients 4 devices. That data streamed into the electronic health record, and patients over 12 months received nurse-led telehealth care. And these were patients in the ambulatory setting who had uncontrolled diabetes, and they were receiving evidence-based modules from a nurse every 2 to 4 weeks. And so what it looks like is essentially we are prescribing these devices in the nurse-led telehealth care model, all within Epic. So it's all pre-packaged in there. We create that data link, and we have alerts also like a medication, where if glucose or blood pressure goes above or below certain thresholds, a nurse gets an alert, something like this that you see in Epic. And so we build that care model around this data flow. And some of the results we were showing that we were able to improve hemoglobin A1C at 12 months, no BP changes, but we also learned a lot of the barriers and some of the facilitators towards this. But the conclusion from that trial, which is nurse-led, is that we were able to fully integrate this into the EHR within the health system. And so the goal is to take that and let's just keep moving this forward, right? If we can do this in the outpatient setting, let's do it inpatient to outpatient, right? And really begin to follow a patient across their care continuum. All right, and I'm a little over time. And so my message here is that nurses, we need to be the architects of future healthcare. And now is our time. And we have a lot of tools at our disposal to do this too. And so I'm not going to be able to go through all this just because of the time, but very briefly, the AI landscape. This is what we're all dealing with. And so I would think about this in 4 different large buckets, right? We have general AI assessment tools, like chat-based tools for productivity, clinical AI, right? Things that might be built within the EHR, productivity co-pilots, and then ambient AI too. And I'm only going to go over a couple of these pretty quickly. So policy to practice. So who here uses AI in their everyday workflow for productivity? Yeah? How are you using it? Just out of curiosity, what ways? Yeah.
Draft a document discussion. It does a great job of like kind of giving you the template and the verbiage and the tone, and then you can really.
Beautiful. Yeah, exactly. And are you on Copilot? Okay. So how many of you are using Copilot within your organization? So not everyone, but quite a few. So this number is increasing pretty quick too. And so for those of you who may not be using this, I just wanted to give quick examples of how useful this can be. And this is where we have to learn from each other in terms of what are some really quick different of these efficiencies. And so we're going to do a quick example. So I found this PDF online from the VA. It's if you don't mind bringing up the PDF real quick, it's of a falls protocol. It's like 20, 30 pages long, right? We're going to pop it into Claude, which is one of the AI tools. Now this is a public AI tool, but I'm not doing anything here that requires any patient information, and I found all of this online too. But you could use Copilot, you could use Google's, you could use Gemini also, but if it's within your own institution, you do need to go with what you have access to. And so, quick example, I'm going to paste a hospital's fall prevention protocol here. I need you to create 3 things: a bedside quick reference card, a patient and family handout, and 3 quiz questions for new nurse onboarding that are NCLEX style, based upon that 30-page falls protocol. All right, we'll see how long this takes. If you don't mind hitting the button there. Hope it works. This works, yeah. Okay. So we'll see how long this takes. I did this last night just to test this out. But you could do anything. You could ask it literally anything. And so this is where like efficiency is going, right? Like thinking of all the documentation that you do, of like using these tools to at least draft something. If it can get you 50% of the way there, you've saved so much time. What I do is I'll take it from like the Claude output, and then I'll go ask Copilot, well, what did you think of that output? Could you add anything to it? Then I'll go to Gemini and ask, hey, what do you think about those two? And then I give it back to the other one, and I have these like, different AIs trying to give me the best answer. And then me as the expert, I edit it all and make sure that it's correct. It's not always correct. So the worst thing you can do is just copy and paste, because you're going to get in trouble one day too. But it's way faster. Like, I mean, there are some things that I'm able to get done like 90% much faster, especially like routine emails and things. Because I don't know about you, but like you get like a flood every day of all of these emails, and you end up staying up late at night. So of course it's going slow. But how about we pop over to the presentation and then pop back over here, just in the interest of time, and it'll pop up. Sometimes it's fast, sometimes it's slow. So, all right, and so we'll come back to that. Okay, and so most health systems are using Copilot now as the licensed, which is through Microsoft. And if you're not using this, you really should. And things are changing so quickly. Every week, I spend about 10 minutes watching YouTube videos to learn about what is the most recent features. That's the best way that I've been able to figure out how to really learn about things, is going online, because it's happening so fast. And so before Copilot, right, you might be sifting through 80 emails before 9 a.m. After Copilot, you can have a inbox summarized by urgency. If you have long reports, you can get them, quickly summarized to really like help you to be able to move things along a lot quicker. And so in the free version, if you will, because there are usually two different kinds, there's the paid license per month, and the free one. You can draft and refine communications, draft policies, SOPs, support project planning. The case studies go on and on. This is also where we have to learn from each other on what we do here. Some quick examples: you can also add images, you can sometimes add PowerPoints, Word documents, right? You can take pictures like all of these notes, you can ask it to quickly summarize it. So taking things that you might have written, and then it can just quickly put it into a document for you. And then if you don't like that style, you can ask it again a second prompt to better organize that. You still need to go back and verify that this information is correct, but it's a lot quicker to be the editor. And if you pay for these licenses, you get even more features too, and it's quite remarkable. In my opinion, it's worth it. And you can do things like search across people that you've been talking to throughout your emails, throughout Teams, and throughout your project folders too. And if you put a / with that person's name, it'll then summarize all of the work that you've been doing with people, right? And you can just ask it, hey, remember a meeting that was 2 years ago that I had with Dean Rebar? Can you remind me all of my past conversations over the past 2 years? And it might like summarize everything for you. So if there's things that you were like searching for, get really, really creative here. Okay. You can ask it all sorts of things, right? Help me plan for today's meetings and create a table. And it goes on and on. So real quick, I don't have too much time. That's at the individual level with Copilot. But what's coming soon on the market are tools that are truly embedded within the electronic health record, where we're able to really sift through what is really dense and often challenging patient records. And I'm running out of time, but there is a video about this tool that we've created at Duke called Scout, and I'm not here to sell you this tool. Tools like this are about to come onto the market very soon. And it's essentially ChatGPT within Epic or within Cerner or within anything. You can ask it anything of the entire patient record. And so we believe that there are so many places within health systems where efficiencies can happen by really reducing the length of time to go through this complex data. And I have a couple quick examples to show you of that we are working on now. So for me, we have this EHR synthesis tool, and I can show you more of this afterwards. But I need somebody to help me find these case studies, go into clinical departments, and just ask people, how can you use this tool? So I created this staff innovation fellowship program based upon the Google model of really buying out staff time 1 day per week to focus on other tasks. And there have been other organizations that have done this too. So I find my nurse champions that get really excited about things. And this is Kim Costin, and so her goal for a 2026, she just started 2 weeks ago, 1 day per week. She's going to be taking that tool and finding really good case studies to find to be able to really find how we can accelerate being able to search be able to search for different information. And I'm going to work with her to really measure those outcomes. And so two quick examples of this, and these are things that I didn't really know about until recently. Colonoscopy scheduling is evidently very time intensive. I don't know if that's at your institution, but it is at ours too, and I had no idea. For our one system, we have 3.5 full-time RNs just doing scheduling for colonoscopies only. And in any given week, we're behind about at 800 because it just takes so long to go through all of the different risk factors, and then to decide where you can schedule patients across different hospitals across our state. And so it takes about 7 minutes on average. And with this tool, we've been able to drive that down to about 2 minutes. So we're really trying to drive forward being able to do, which is just one task here. Kim used to work in the ICU, and she recently started in our quality office, right? Whenever there's sepsis, CODIs, or really any other kind of different harm like that, there's an extensive review, right? Because you have to report all of this. There was a recent example where there was a sepsis case, and it took 3 weeks to go through that entire record to document everything. I was like, Kim, all right, take all of that work, put it into this new EHR synthesis tool, kind of like GPT, and it got the output in 1 minute, and it was exactly the same. I'm like, oh. There's more out there. There's so much out there, right? And so then we can keep going, right? We can think about, well, the bedside nurse who is, especially inpatient, who is doing change of shift, right? We have patients, we know all of their history, we all know what's going forward. Can that AI synthesize what happened during the shift and what's up to come? And we can really make it faster to do that change of shift, right? And then we could tailor that to every specific nurse. Like, the possibilities are endless. We just need to identify these use cases, do them, and learn from each other and share all of this. And honestly, I don't think we can publish this quick enough because academia doesn't quite work like that. So, all right. Can we quickly go back and see if Claude did it? And then I'll wrap up soon. Do you want me to end by 10 o'clock? Okay, sure. Did it work? Oh, of course. Let's see. Did I run out of data? Oh, there we go. So it took that 30-page fall prevention thing, and it did those 3 tasks, and it also visualized them. It's fall prevention quick reference, and if you scroll down real quickly on the side here, it also, this is for patients and families and everything else. And so it's a lot easier to go back and edit all this to make sure it's correct. But I mean, that would increase efficiency by 95% or so, right? So, all right, and we'll hop back over to the presentation and I'll wrap up. So, all right. So it's important that as nurses, we really begin to develop digital competencies around AI literacy, data fluency in systems and informatics thinking, so that we can really leverage these tools that have just started. I mean, there is so much more that is also going to be coming to. We need to lean into continuous learning, and for me at least, it's every week to really learn how to use these tools. There are practical steps we can all take to start innovation in our own settings. Identify your pain points. Start with a small coalition. Pilot with purpose. capture that evidence and those outcomes, and then scale with intention. And you can have all of these slides afterwards too. So really, the future of nurse-led innovation is nurses being the architects. Truly, virtual care is going to become a standard. I mean, everyone has a phone in their pocket. I don't think that's going to change anytime soon, even though certainly on some days, I feel like this too connected. AI augmented practice, nurse-designed solutions, and a sustainable workforce. And so some of the key takeaways are that innovation in nursing, it really spans clinical processes, care models, technology, and it really starts at the bedside and the boardroom. It's really both. For the case study on virtual nursing, we are seeing measurable value, as I'm sure many of you are too. AI tools are rapidly entering healthcare. A year from now, the landscape is already going to have evolved quite a bit, and it's our time to really build the evidence, and remember to start small and scale with intention. So I have a lot of people to be thankful for. It's not just me, whether it's colleagues, faculty, nurses, and students also. It takes a lot of people to do this work. And so I'm excited about next steps, and I would love to talk about what challenges you see, what has gone well, and also what has worked, and what you see as the biggest opportunities for nurse-led change. All right, thank you.